welcome to The Extra Mile. I'm Linda Boudreau. Our guest today is Sherri Daigle. Sherri is the midwifery program coordinator at South Louisiana Community College. I knew I was going to. I do that every time. And the midwifery program is new, fairly new, and I think it is a most exciting innovation for our community college system. So, Sherri, thank you for being here today.
Yeah, you're welcome. I love to be here.
So, for those who don't know, what is midwifery anyway?
Midwife is from the Old English term that means with woman, because women have been having babies for many generations. The hospital and the technology and the obstetrician, which is just another word for midwife, it comes from the Greek instead of from the Old English. Women traditionally attended women in childbirth.
Back in the old days.
Prior to the last 2 or 3 generations in the U.S., yes.
Okay. So what happened? How did we shift from, women being with women to men doctors being with women?
That's an interesting question. It's been a cultural shift for the past 100 years or so that as allopathic physicians, came to be in more power in the United States, they helped develop the medical system that you see. Prior to that, homeopaths were physicians. And I don't want to tell them my allopathic friends, they're wonderful people, but they were the snake oil salesmen of the day in the 1800s.
Things change.
And they certainly have changed. Science has become more predominant in medicine. The Flexner report in the 1910s, I can't remember the exact year, denoted what would be important in a medical facility. If you weren't in the top 10 in the Flexner report, you got weeded out. So any midwifery schools, which there were several at the time, homeopathic institutions and other alternative healthcare providers got phased out.
Okay. So that was a shift in. How come childbirth became viewed as a medical condition anyway, as opposed to, say, a natural phenomenon?
You're talking about research that goes back to an era where we were not properly, we didn't have antibiotics, we didn't have blood products, we did not have cleanliness in the home, we didn't have an adequate diet. So there were a lot of babies that did die in childbirth, a lot of women died in childbirth. And what you'll find is that over, I'd say past the 1920s, things began to change because people could use more sanitation. More sanitation was available, running water was available, a steady food supply as people moved to cities. So that what we give credit to the medical community for some of these changes actually may be more cultural shifts.
Okay, but as a result of that, then babies started being born in hospitals rather than at home. And am I correct in saying that we are seeing a shift back, at least a slight little
It's slight right now. If you look across the world at developed societies, about 3% of babies in England are born in the hospital.
3% are born in the hospital?
Excuse me, I didn't say that right, in the home.
Okay.
So that across the world in industrialized countries, hospitals are still usually the most common, but Holland has as many as 40%, England only about 3%, the U.S. it's up to as much as 2% in some places.
Okay.
It is coming back. It's a slow comeback.
Now, are midwives, well, first of all, midwives are, who are the midwives?
Okay. There are several different types of midwives in the United States. One is the certified nurse midwife. So unlike European countries, the nurse goes to school for 4 years, then goes to a master's program, and that's quickly becoming, they're looking at it being a doctorate program. About 1.5 years where she learns the rudiments of childbearing. What's different about childbearing? What do you have to do to prepare? What are the safety mechanisms? How to treat complications? How to keep people normal? So that program that they go to for 1.5 years closely resembles the program at SLCC where it's a 3-year program start to finish.
Okay.
So that's the certified nurse midwife. She traditionally practices in a hospital setting.
I was going to ask that.
Yes, not always. In Louisiana, they are all working in hospital settings. We only have about 20 in the state. I could be wrong by a few, but
give or take, huh?
Give or take a couple. There are about 50 that are licensed in the state, only about 15 to 20 practicing.
That's not very many. But.
And then the certified professional or licensed midwife is legal in about 28 states based on the North American Registry of Midwives. She tends to not work in an institutional setting. She tends to work either in a birth center or in the woman's home. Okay.
So what are I guess all of this is really driven by the mother's preference pretty much and her overall medical condition, her overall well-being. But what would be the differences and the pluses and minuses of each of the 3 environments?
Okay. There's more and more research being done on how helpful is the hospital. And we know that for a high-risk woman who is sick, has cardiac conditions, has blood problems, has blood dyscrasias, she has diabetes, or she has multiple pregnancy, she may be better off in a hospital. But what happens in the hospital for the normal low-risk woman is that she's having far more intervention that leads to more intervention and is very costly and does not produce a better outcome. So some of those women, and I would say the healthiest of the healthy, may want an out-of-hospital setting.
Okay. And of the birth center versus the home, what are the yays and nays for those two? Or is that just preference?
I think it's perception, and the preference is based on a perception. I think that many women feel that the birth center is an intermediary between the hospital and the home. What I would tell you it is, in my years of experience, is that it's a home birth at somebody else's home.
Okay.
So you do know where everything is all the time. Things don't have to be portable. But I don't believe there's a great degree of safety above a home.
Okay. So let me ask you, if somebody wanted to do a home birth, would they have to make a lot of preparations in their house?
Not really.
I mean, what would you have to do to get ready for that?
Well, of course, a woman wants her home to be clean. She wants to have made sure that food is on hand. The hospital would not run out of food or electricity, so if a hurricane's coming, she may make other preparations. She wants to make preparations for her children. The plan has to be in place for whether they're going to be at home with a caretaker or whether they're going to grandma's house.
Okay.
The midwife tends to bring, if the woman is choosing a water birth, the midwife brings the tub with her. It comes with a sterile liner, so each woman has their own liner.
So she doesn't have to clean out her tub ahead of time?
She does have to have a potable water hose that's been cleaned. She has to have she has to have electricity. We want her to have a phone, even though the midwife would have a phone also. But very little in the way of preparation. The medical items and the disposable items come with the midwife. You've pre-placed them. So not a lot.
So it's really not that complicated. Well, it's complicated, but it shouldn't have to do that much of it.
Not that complicated,
okay.
No.
So what was going on in the Louisiana higher ed system when they made a decision to invest in midwifery in our community colleges, which to me is just leaps ahead of where I thought we were. I mean, I'm very impressed by that.
It's light years ahead for Louisiana. The Louisiana Community and Technical College system saw the need for, having looked around the country to see what's moving, what's shaking, and healthcare careers is number one. It's the biggest industry in the United States at this point. So training people for a new healthcare system that uses less money, that still has appropriate technology and trained providers, I think they were looking a little bit ahead. We have one champion that's on the college board that has been very helpful and instrumental, and saw South Louisiana Community College as a pocket that's alternative enough, so I guess it's hip enough, but still has enough clinical sites to provide for the student.
Okay. So the program started last semester.
We finished our first semester of students. We have 3 that are ready to certify as a doula. A doula is a woman, traditionally a woman, who attends a lady in childbirth but is not the medical health care provider.
Okay, and that is also something that you can get certified in?
Part of their original, the foundational courses include childbirth education, education and certification, and doula education and certification.
Okay, so she doesn't have, a student doesn't have to go on to be a full
She could
midwife.
stop. She could stop there and attend women in home birth center or hospital settings as a support person.
And what does a support person do? Is that like your coach when you're doing
That's exactly what it is. Yeah. That's exactly what it is, and it's been shown to reduce C-sections for some of the same reasons that midwives do. Reduce C-sections, improve comfort, improve satisfaction for the patient. So because childbirth is sometimes medical, but usually sociocultural. It's a spiritual event. It's an emotional event. It's not just a medical procedure. So that having someone who is signed on for you and not just catching the baby at the foot of the bed is found to be very helpful. Tons of research. It's all positive.
Do you think that this whole kind of thing that, women, when they're on TV shows and they show this woman giving birth and she's screaming and she's lying down and she's just in such agony. Yeah. Do you think that creates like a level of fear and anxiety and kind of misrepresents childbirth?
Absolutely. The drama that we want to portray so that we make the top 10 ratings on TV has been detrimental to what women think about their abilities to give birth and their abilities to be mothers. Birth is risky, birth is scary, birth is painful, and it is painful. It's difficult. It's a difficult process to endure. It's not hideous, and it's not something that's not doable for a woman.
And it's not forever.
No.
It's like time limited.
Yeah, I was watching last week a program, that funny program, and it's Frasier, I think you're familiar with that. And the taxi cab driver goes into labor. Rather than the person in the back going into labor, the taxi cab driver's in labor, and she goes from a squinchy face that's a little concerned to pushing a baby out, screaming, yelling, it hurts, and of course everybody's silly and doesn't know what to do. That's not the way it takes place. You know, a woman it's a pretty predictable pattern. She has a few hours to a day or so of early labor that is not hurtful or damaging to her or the baby. It's a warning. She goes through a few hours of active labor that are intense but very doable, and a few minutes that are very difficult. And that's usually when a woman will say, I cannot do any more, and her support system is saying, you've already done all the work. It's really kind of late for medication. So it's a private and sometimes a dark place, but the woman who has gone through that is very happy with her birth. She rarely turns around and says, you should have given me an epidural.
Right. I don't think
I've never seen it.
I've never heard that either, and I know quite a few women who've had natural births. So in all this movement that's happening with midwives and doulas and all that, what is the role of men? Or is this really a woman-to-woman predominantly?
It's both. I think that the way childbirth has changed in the past 30 years with the inclusion of midwives is you're returning it back to the family. So, I mean, it is a feminist issue. You can't do it without thinking of the woman first. But when she's able to make her choices and includes her partner, which usually there's been a father involved, her partner is on board and able to feel they do it the way their family does, whatever they're doing. So if she wants him to be a bigger support person, he can do that. The midwife and any other good provider is very inclusive of that partner and her children if they're there. There are women that don't have that sort of relationship, and they might be relying more heavily on the midwife or doula and allow their partner to take a secondary role that he's comfortable with.
And not every partner wants to be involved in it. There are some who are still very, very afraid of that. I mean, I've talked to men who say, oh, no.
We educate around that and then give them the freedom to make that choice.
Okay. And just in terms, are midwives always women?
Yes and no. I've been asked that before. We would certainly accept a male in the program. He would have to understand that most women want women with them. There are several C&M male midwives. They tend to work in
What's a C&M?
That's the certified nurse midwife that works in a hospital. They tend to be in military facilities where you don't always have the choice of providers. It's being provided for you. But, I mean, they would be as good at it as anyone else.
Technically, but again, I still think that emotional, spiritual kind of connection thing, unless you know, it's sort of a woman thing.
That's right.
You know, it really is.
They tend to want a female. Yes.
So is there room in the curriculum for more students? Are you full? Are you recruiting? What's the deal?
We are full. The first year really worked out, it was quick and easy. Everybody that applied, I think we had one or two people that were not quite ready, so they didn't get in. Their prerequisites had not been fulfilled. We had 10 spots. We had 9 students. Next year, when we take the incoming course in January, I expect there to be a little more competition. We cannot at this point take more than 10 because we don't have tons of clinical sites. So that's going to have us pretty full.
So really, though, but the key then is to, over time, as this gains acceptance, have increased clinical sites.
Yes.
Okay.
Yes.
And when you say clinical sites, you talk about what, hospitals?
This is like a medical student trains in a classroom, but he or she also trains in the hospital room with the patient or in the clinic with the patient and the more experienced physician. The same thing happens with midwives. You can have a certain number of observations, which we've just increased. Our national standard has just increased.
And we follow national standards here, right?
We do. Okay. We do. Our state law has just changed to keep up with the national credentialing. The woman has to have at least 10 births that are observations, at least 20 births that are observation assists, and they're catching, they're helping to catch, they're involved in the birth, and 20 where she's primary. So that's a total of 50 births in those capacities. That's pretty much like a nurse midwifery training program. Okay. So she will, at first, do a lot of observations in clinics and in practice settings. Then she will walk into the practice of the midwife and be an assistant, an official assistant. That midwife will then allow her to do those last 20 right there with her.
So really, if I'm hearing this right, then the training for a midwife is by another midwife.
Yes.
So it's not like just going in with your OB and watching an OB do a delivery.
What's very different is what we call a continuum of care.
Okay.
Because what you won't see is a stranger. If it were a public hospital, a stranger would come in and deliver your baby. After clinic visits where you might have gotten a different nurse practitioner or physician every time you come in. Hundreds and hundreds of women, maybe 20 doctors. This is a relationship formed between one midwife and whatever students or assistants are involved, and that one woman through the pregnancy.
Okay.
This is why I think it's so effective, is you've built a relationship, the woman trusts the midwife, and the midwife knows what to trust about the woman. And when things don't look good, it's caught immediately. It's not a woman on a machine, and the machine blinks or blips the right way, and then we go off to surgery.
Right.
It's very personal and intimate.
So a lot of times then something that maybe looks a little scary or a little, might raise an eyebrow or be a bleep on a machine is something that can be managed if there's trust and confidence between the partners. Often there are some things that if you catch early, you can reposition the mother and keep your eye on it. It never comes up again. There are other things, if they're not caught early, then the baby is compromised. Okay, and
So-
those are and that's what I guess the concern. And I guess as much as we want to be, kind of open-minded and kind of, ahead of the curve and all that, there is still that fear of that what if?
Yes.
What if we miss something? What if something
Taking
happens?
care of all the bases. That's
Yeah.
right. That's right. So the baby is in an out-of-hospital setting or in midwifery care. I think the misnomer is, well, in a hospital we listen to the baby. So do we. In a hospital we have anti-hemorrhagic drugs. So do we. In a hospital we have sterile instruments. So do we. In a hospital we can take blood pressure, and so can we. Well, we can suture the client if there's any damage below. So can we. So everything that's necessary in a hospital setting except the cesarean section. And it is very much, we are wrong, we are incorrect when we think that a healthy baby always just becomes unhealthy like that for some unforeseen circumstance. Almost every cesarean section that was necessary had a predisposing factor that you could look at in the chart and say, here's why it happened. So we knew it was going to happen. And that's not the case with the women that we're seeing. They get risked out and screened out very early.
So let me get this right, because we're doing a lot of cesarean sections. It
Yes.
seemed to be a bit of a surprise to people. It's like you think you're having this perfectly normal pregnancy, and you're going to have this vaginal delivery, and then all of a sudden you go in and you have a section. You're saying that really that should, if it was a necessary section, it should have been picked up earlier.
If it was a necessary section, there's a predisposing factor.
Okay.
And I would stand by that because the rate of cesareans that need to be performed to save life and limb is somewhere between 8 and 10%. That's a high estimate.
Okay.
The number that we're performing in the state right now is 46%.
46%.
So you wouldn't have to be a researcher to understand or to believe that they're not all necessary.
So what is the advantage to doing a section? There's got to be some advantage somewhere to someone.
Doctors become tired. Malpractice is expensive, and nobody wants the lawsuit for the what if, because you pointed it out earlier. We don't want to miss an opportunity. We don't want to find out we were wrong when we thought it was safe. It's better to just do that cesarean, get it over with, and then we know we have a good outcome.
Okay, so it's really a kind of outcome driven in that we don't want to take a chance.
And we don't want to take a chance. But the perception that's incorrect is that we're taking chances, because the truth is the baby's lungs may not be developed. The mother may not have been ready to have that baby. Blood loss is almost always more with a cesarean section, and maternal death goes up as much as 8 times. So that the lives we're saving
Wow, so
on the
there's a
front
lot
end,
of risk involved in all of that.
there's a great deal of risk to a cesarean section. And informed consent implies that the woman knows that before she consents to it, and she does not know that. Most of the time it's a piece of paper like this with little bitty print. Who has time to read that when they've just been told they're in a risky situation?
Yeah. Mostly you're just scared.
You're just scared.
And so whatever you tell me to
It's
do,
fear-driven.
I'm going to do that.
Absolutely.
Let me ask you something else I'm hearing more and more about with the young women I know that are having babies. And I don't know if this has to do with midwifery, but it does in terms of just how we manage babies, and that's induced labor. Now, with the midwife, you're never going to have an induction, I would think. You're just going to say, okay, this child wants to be a Capricorn, and you're going to wait till the stars are aligned.
There is a window of 5 weeks where a woman is considered safe to deliver a baby. That starts at 37 weeks, and some might be okay at 36, but prior to that, the lungs may not be well developed. After 42 weeks, the risk goes up sharply that the baby may be indeed post-mature. There might not be enough fluid around the baby. The placenta may not be functioning at its best, overripe, so to speak. 5 weeks is a long time.
Especially when you're at the end of your pregnancy.
Well, and that's part of it. You hit the nail on the head. If a mother is 37 or 38, she may be encouraged to go another week. If she's 40 and she's swollen and she's tired and her back hurts, if you said, let's go ahead and induce you Friday morning, she's probably going to say yes.
Oh, yeah.
Yeah.
Oh, yeah.
You've been in that place before. You're uncomfortable.
Yeah.
So it's an opportunistic situation. But it does not mean that the mother is unsafe. Now, last time we were here, we talked about the initiatives to lower the induction rate, and that has been going well. I can't quote you the number, but with fewer babies being induced, NICU admissions for babies, that's the neonatal intensive care unit, admissions to the NICU have decreased dramatically, like by half.
Really?
So that the inductions with premature babies, because we don't know that. We don't know when that baby was due. If there's no medical indication, then let's not mess with it.
Because that baby's not ready.
Not ready.
Yeah.
Not ripe yet.
So people are starting to look at these things and begin to maybe reconsider and think through it a little differently?
Yes. I don't know that the women know that. I think that the doctors certainly do.
Okay. Well, let's let women know, because there are a lot of women out there having babies.
Yes.
And grandmothers.
Well, babies can't read calendars.
No,
so they only know if it's a healthy situation that nature knows better than what we do.
So let's let them.
Babies are also inconvenient. I can add that, right?
And I guess that's part of it too. You know, if you can schedule around it. I mean, I know people that have been induced so that their children could have the same birthday.
There's the designer birth where you go in and schedule your C-section and have your tummy tuck at the same time. And I just think, I don't know, maybe I need one, but I wouldn't do it, right?
So let me ask you this, because, we often think that, the complementary and alternative kinds of medical practices, such as and I guess midwifery falls into that category to some extent, are in some ways maybe not always working well with our mainline medical system. But do you find that we're finding ways to kind of join together for the real betterment of all of us?
I think it's on the horizon. I think that if I came to you and you're selling brand A and your life has been invested in brand A, and I come along with brand B, that could be better for some people and it could be more cost effective and increase satisfaction, you're still going to have a problem with that. It messes with the status quo. It messes with where the dollars are being spent right now. There are many reasons for that. Some are strictly political.
Yeah, and some are driven by money, but the times they are changing.
They are changing. And we cannot continue to spend at the rate that we have to get the poor outcomes we've been getting.
And to me has been the most amazing thing is that, no matter what we say or do, our outcomes, our health outcomes are not very good.
They're abysmal.
And it can change. So if anybody watching today is interested in becoming a midwife, what do they have to do?
Yeah, let me reiterate the program. The program is 3 years from beginning to end, 2.5 semesters that are 2.5 years in midwifery, where you go from childbirth educator, doula, apprentice, student midwife to ending with a license in midwifery and it's called certified professional midwife through the North American Registry of Midwives. The woman, usually it's a female, would then qualify to run her own business as a private practitioner of midwifery.
Okay, so she could just have her own clients?
Yes.
And could she also at that point then take on apprentices?
She can. We ask, and the national credential asks that you're not in business, but in practice for 3 years before you take on students, so that you have a more wisdom and experience behind you. You're not a novice midwife. And
I'm asking that because it seemed like earlier we said that one of the real barriers to more people getting into this is a lack of opportunity to get the skills that you need. And so if we can find ways to build capacity, it can move this along.
It just won't be overnight. It's slowly and by degrees. It's going to take a little time, right?
Okay. So how are things at the school? Y'all off for the summer now and getting ready for?
Not off. Busily getting ready for the fall semester, working on accreditation with the accrediting bodies, designing more clinical sites and training preceptors, and moving in all the right directions.
Well, I think it's just very exciting that y'all are doing. How did you get into this anyway, Sherri? Just real quickly.
It's a good question. I had a baby the way most women do, and I was a shiny, bright-eyed kid and of 21, and I wanted a natural birth, and I knew that. And I was not taken seriously. I was threatened with a C-section after I quickly delivered because they used so much Pitocin to induce me that baby literally flew out and almost had nobody to catch.
Ooh.
And I learned from it that I didn't want to be done that again. I wasn't going to spend my money to be treated that way. So I found a midwife with a second birth and fell in love with the profession, fell in love with the training, fell in love with the people that we see and meet, and I love helping women that way. So whether it's training or delivering.
And so now you're making a real difference in women and families' lives.
We hope. One family at a time.
That's right. One baby at a time.
And one baby at a time.
Thank you so much,
Thank
Sherri.
you.
And it's good to have you back again. Take care.
You
And thank you for watching The Extra Mile.